Secretary Dr. Naveen Malhotra, President-elect ISA National Dr. Venkatagiri, Senior Consultant Anesthesiologist Ganga Hospital, my friend, Government Council member, JUM in Regional Anesthesia Dr. Bal Venkat Subramaniam sir, and Dr. Bhimesh, past Secretary ISA National, Dr. Kiran, GC past GC member ISA National, Dr. Mahesh Babu garu, past ISA AP President, and Dr. Suset Srinivas, Secretary, my young and dynamic Secretary, and dear friends, Dr. Chakkara garu, past President ISA National and Chairman Indian Association Council. I welcome all. Now I'm handing both to the our two ISA national leaders, Dr. Bhimesh and Dr. Kiran Kumar. Over to them. Thank you very much. Kiran, Bhimesh.
Hello, can you hear me?
Bhimesh.
Yes, sir.
Yeah, good evening, everyone. I hope I'm audible.
Yes.
Yeah, thank you very much. Thank you very much, Venu, Dr. Srinivas, for giving me this opportunity to be here with all of you. For I think the 16th webinar consecutively, AP has been in the forefront for all these things, and I'm also very happy that today we are coming out with the e-newsletter of the Andhra Pradesh state. That's wonderful idea by Dr. Venugopal. Wonderful. I wish the e-newsletter also all the success, and I request Kiran to continue with this meeting. Dr. Kiran, please.
Sir, good evening, sir. Good evening, all of you. President ISA AP State Dr. Venugopal, Secretary Dr. Suset Srinivas Rao, and the National Past ISA Presidents Dr. Chakkara sir and Kamesh Rao sir, and the National Past Secretary Dr. Bhimeshwar, and present GC member Dr. Bala Venkat sir, our National President Dr. Murali sir, that you are here, I thought you left. I wish ISA AP State, they are doing excellent work, and they have been conducting, I think this is 16th webinar. They're almost completing the Kerala people. Very good, Dr. Venugopal and Suriseti Srinivas. Your team is doing excellent work, and bringing this e-newsletter during this COVID time also. It is a very good thought you have, and I congratulate you, and I wish all the best for the e-newsletter. Over to the President.
Thank you, sir. Thank you very much. With permission of the members, I request Dr. P.S. Kameswara garu, Dr. Mahesh Babu garu to please take over the ISA webinar topic. Let us do the first topic. After that, we'll release the ISA e-newsletter. Over to Dr. Kameswara garu and Mahesh Babu garu, please.
Good evening, everyone. Very happy
Good evening,
that AP State Branch is doing regular webinars. I think this is the 15th webinar in a row, and you have superseded Kerala webinars. And Kerala also has done wonderful post-graduate programs of 5-6 hours duration also, case discussions. I participated as a moderator also in those, and AP branch also very actively involved in conducting these activities. And I must thank for the encouragement given by our National President Dr. Muralidhar Joshi and Secretary Dr. Naveen Malhotra, and all the past national presidents who are constantly attending this program. And I appreciate Dr. Bala Venkat, who is present GC member, taking active interest in participating in our webinars. Very useful talks on regional anesthesia. I must especially thank him for taking so many topics with all his team members. And now regarding the topics today, now I request Dr. Mahesh Babu to proceed.
Good evening, sir. Good evening, all of you. It's my pleasure to introduce the first speaker, Dr. Venkateshwaran G. He was born in 26th March 1975 at Coimbatore, and he had MBBS, DA, and DNB all from Coimbatore Medical College. He participated as a faculty member in AORA several times. He is a life member of ISA, IMA, AORA, ITAX. He is a member of PPLSSS, limited faculty at more than 25 national conferences. I proudly present you, sir.
Good evening, everyone. First of all, I'd like to thank the Andhra Pradesh State ISA and Dr. Balavenkat for giving me an opportunity to talk in this webinar. My topic is lumbar and sacral plexus block. Before I go into the presentation, I would like to start my presentation with a small case scenario. We received a 55-year-old male with a gangrene of left leg. On arrival, the sugars were 540 milligrams. HbA1c was 11%. The urea was 90 and creatinine was 3.6. This patient also had an ischemic heart disease with an ejection fraction of 30% with severe left ventricular dysfunction. The plan was to do a left Ebony amputation. So we just stabilized this patient because the sugars were very high. We just started an IV insulin infusion, and then we took him for the surgery in the form of an Ebony amputation. And this was done under PNS guided lumbosacral plexus block. So during the procedure, there were no hemodynamic disturbances, and the patient was quite stable in the post-operative period also. Why lumbosacral plexus block for these type of procedures? That is, it gives a complete anesthesia to the lower limb. There is no hemodynamic disturbances even when the ejection fraction is 30%. The tourniquet can be applied and the surgery can be done without any blood loss. Patient in sepsis is also not a problem. It gives a good post-operative pain relief of more than 8 hours. In our plastic surgery department, we have a diabetic foot department as a subspecialty where we receive a lot of diabetic foot cellulitis with necrosis of foot like this. So all these patients come with severe autonomic neuropathy. Not only this, and these type of patients also, we can see the gangrene of the lower limb and also cellulitis of the leg. They all present as an emergency for the procedures. They all come with severe autonomic neuropathy. And this is also a diabetic foot with necrotizing fasciitis, came with severe sepsis, so we have to take him as an emergency. These patients also will have a severe autonomic neuropathy. So it's very important, and whenever we try to give some type of central neuraxial block like spinal or epidural for these patients with diabetic foot with autonomic neuropathy, they land up with exaggerated hypotension and which don't respond to the routine vasopressors. And they have high chances to develop epidural abscess, urinary retention, and the hypotension can cause early thrombosis of the ischemic leg. So it's very important that you have to assess the autonomic nervous system by doing both parasympathetic test as well as sympathetic test. And the parasympathetic test we can do is resting heart rate. And this is a parasympathetic test. The normal one is less than 100. The borderline is 100 to 110 per minute. And the severe dysfunction is more than 110 per minute beats. And then we also see the sympathetic test. The most important sympathetic test that we do is the BP response to standing, from supine to standing. So from supine to standing, we can see the blood pressure response. So normally the systolic BP will fall by less than 20 millimeters of mercury, and the diastolic will fall by 10 millimeters of mercury. But here, you can see that it can make it as a borderline when in this 10 to 20 millimeters of mercury systolic, and more than 20 millimeters of mercury systolic is said to be, the patient is said to be having autonomic neuropathy. If the patient cannot stand, then we can do a sustained hand grip test for about 5 minutes with a dynamometer. So we just check the diastolic BP after 5 minutes. The normal value will be more than 15 millimeters of mercury after 5 minutes of hand grip. Whereas in borderline dysfunction, it will be 10 to 15 millimeters of mercury. In severe dysfunction, the patient will have less than 10 millimeters of mercury. So by doing all these tests, we can assess the severity of the autonomic neuropathy. So in early dysfunction, we'll have 1 or 2 borderline abnormal tests with respect to the heart rate. In definitive dysfunction, they'll have 2 abnormal tests in response to heart rate. Whereas the severe dysfunction, at least one of the blood pressure measurement, that is the sympathetic test, like systolic BP and diastolic BP will become positive, then these patients are said to have severe autonomic neuropathy. So what we have to know is when the patient has got an early dysfunction, or a early dysfunction, you can go ahead with spinal or an epidural. Whereas when the patient has got a severe autonomic neuropathy, then we should not subject to spinal or epidural. It's always important. We can do it under a lumbosacral plexus block or a peripheral nerve block. So when you consider this, peripheral nerve block and lumbosacral plexus block, they're very cost effective for the diabetic foot surgeries. We can see the last year's statistics, which shows about 677 diabetic foot surgeries were done. And we can see about 100% of the diabetic foot surgeries were done under regional anesthesia. General anesthesia is almost zero. And among that, 85% of the regional anesthesia was done under peripheral nerve blocks. And we did almost about 57 procedures under lumbosacral plexus block. So these procedures are usually in the form of below knee amputation or above knee amputation for the diabetic foot surgeries. At this juncture, I would like to thank Dr. Sandeep Diwan of the Shan City Hospital, Pune, who taught me the lumbosacral plexus block in one of the AORA workshops. So coming to the history, it was started in the year 1974 by Winnie. So he used landmark technique or the loss of resistance technique to identify the lumbar plexus. It was later modified in 1976 by Chen, and he also used loss of resistance technique. And only thing is he was bit lateral. The insertion of needle was bit lateral. And only in the year 1989, the Parkinson introduced the identification of lumbar plexus block by peripheral nerve stimulation. In 2002, Capdevila modified Winnie's technique of peripheral nerve stimulation. In 2001, it was Kirchmeier who introduced ultrasound guided lumbar plexus block. Coming to sacral plexus block, it was introduced in the year 1993 by Mansoor. So he did a parasacral approach of sacral plexus by nerve stimulator guidance. So this is the history. So what happens is whoever who has got an insertion more lateral to the mid-spinal line, the complications are less. Those who have gone closer to the mid-spinal line, the complications are more. That's the reason from the history. First, coming to the anatomy of the lumbosacral plexus. The lumbar plexus is formed by L1, L2, L3, and L4 of both the divisions of L1 to L4. And the ventral rami of L4 gives a small branch to the L5 and joined to form the lumbosacral trunk, which acts as a communication between the lumbar plexus to the sacral plexus. The sacral plexus is formed by S1, S2, S3, S4. And this lumbar plexus is formed within the psoas major muscle. And this is the cadaveric dissection, means slide showing the lumbar plexus present within the psoas major muscle. And this is the picture of the CT contrast of lumbar plexus block, where block was given with the contrast and the CT taken. You can see the whole psoas major is stained with drug. And coming to the branches of lumbar plexus, the branches of lumbar plexus are iliohypogastric, ilioinguinal, genitofemoral, lateral femoral cutaneous nerve of thigh, femoral nerve, obturator nerve. And you can see all the branches of lumbar plexus, all the branches of lumbar plexus arise from the lateral border of the psoas major, whereas the obturator nerve arises from the medial border of the psoas major. This is anatomy. Coming to the sacral plexus, once the sacral plexus is formed, they come out through the greater sciatic notch, and this is covered by the piriformis muscle. They come out through the inferior border of the piriformis muscle. The main branches are superior gluteal nerve, inferior gluteal nerve, peduncle nerve, nerve to obturator internus, posterior cutaneous nerve of thigh, which is very important, and the largest nerve is the sciatic nerve from the sacral plexus. Coming to the dermatome, myotome, and osteotome of the lumbar and sacral plexus, the lumbar plexus dermatome, it supplies the anterior and lateral aspect of the thigh and also the medial aspect of the leg, whereas the sacral plexus supplies the posterior aspect of the thigh and lateral and anterior aspect of the leg. And coming to the myotome, the lumbar plexus supplies most of the, it supplies the quadriceps muscles, and the sacral plexus supplies the hamstring muscles and the legs of the anterior and lateral compartment. Coming to the osteotome, both the hip joint and the knee joint are supplied by femoral nerve, obturator nerve, and the sciatic nerve. So this is about dermatomyotome and osteotome. Now we go to the sonoanatomy of the lumbar plexus. So coming to the sonoanatomy of the lumbar plexus. So we just keep a probe. We just keep a low frequency curvilinear probe just parallel to the spinous process at the level of the iliac crest with the marker placed cephaloid. So once you keep this, then you will be able to see the structures in the following this view. So here we can see it is the kidney at the level of L3, which is moving with respiration, and we can see the transverse process. So this transverse process, you can see this is L3, L4, and L5 transverse process. And this transverse process, almost this view looks like what you can call it as a trishul, or the trishul, or we can call this as the trident appearance, called trident sign. These are the three transverse process. And coming to the sonoanatomy, you can see this is the erector spinae muscle, and these are all the transverse process. And in between the transverse process, what you see is the psoas major, and the lumbar plexus will be present between the posterior 1/3 and anterior 2/3 of the psoas major. And this is the retroperitoneal space. So this is the sonoanatomy of lumbar plexus in longitudinal scan. Next, we'll go to the sonoanatomy of the lumbar plexus in Shamrock's method. That's a common type of method that we do. So what we do is we just keep the curvilinear low frequency probe just above the iliac crest. And once you keep just above the iliac crest, what you see in the ultrasound is you'll be able to see these structures. We can see this is the transverse process. So this is the transverse process of the vertebra, probably the L4 vertebra, and this is the psoas major muscle, and this is the erector spinae muscle. This is the psoas major muscle, and this is the erector spinae muscle, and this is quadratus lumborum, and this is the transverse process. And what you see will be, this is the, from the transverse process, you can see this is the body of the vertebra, and what you see on the posterior aspect is the it is the dura. It's the dura, and it is the intrathecal sac, and the lumbar plexus will be seen in the psoas major muscle at this region. And once you put the color Doppler, you'll be able to identify the IVC. If in case of right-sided scan, in case of left-sided scan, you'll be able to see the aorta, abdominal aorta. So this picture almost looks like the face of a rabbit or a face of a bunny. So therefore, this vertebral picture looks like a face of a bunny. Therefore, we can call it as the bunny sign of lumbar plexus in Shamrock's method. And coming to the sonoanatomy of the sacral plexus. So for that, we have to draw a line from the PSIS to the greater trochanter. So this is the PSIS and to the greater trochanter, and we divide it into medial and lateral aspect. We keep the curvilinear probe over the medial aspect, then you'll be able to see the iliac bone as a long bone, as a straight bone. And once you scan it down, you'll be seeing there will be a break in the iliac bone. That's because of the piriformis muscle. And you will be able to see the sacral plexus here. And the close, this thing is, once you see this, there's a pulsating vessel there. You put a Doppler, that's nothing but the inferior gluteal artery. So the plexus which is present next to that is the sacral plexus. So this is the sonoanatomy of the sacral plexus. What are the indications of lumbar and sacral plexus block? The lumbar and sacral plexus block forms the sole anesthetic for the entire lower limb procedures. The perioperative management of TKR and THR and knee surgeries can be done under lumbar and sacral plexus block. And even this above and below knee amputations in multiple comorbid illness with the low ejection fraction and LV dysfunction and sepsis can also be done. The patients with severe diabetic autonomic neuropathy coming for lower limb surgeries can be done under lumbar and sacral plexus block. In trauma, femur and tibia interlocking can also be done. Suppose if the patient has got a cancer metastasis over the sacral plexus, we can give a sacral plexus block to relieve the cancer pain also. Coming to the contraindications, the absolute contraindications are patient refusal, local anesthetic allergy, local skin infection, and coagulopathy. Try to avoid lumbar plexus block in an INR of more than 1.5. Relative contraindications are sepsis, prior retroperitoneal surgery, and neuropathy of the lower limb. These are all the contraindications. How will you identify the lumbar plexus block? The lumbar plexus. So identification of lumbar plexus is by 3 methods. One is by loss of resistance, peripheral nerve stimulation, and dual mode, where we can use both the ultrasound as well as the peripheral nerve stimulator. The loss of resistance is not done nowadays. We are commonly using the peripheral nerve stimulator and the dual mode. So coming to the lumbar plexus block by PNS guidance. The general considerations are, we should need a consent, a good IV access, a standard monitoring in the form of pulse oximeter, blood pressure, and ECG. The patient should always have a light sedation in the form of fentanyl and midazolam. All these deeper plexus blocks always better that you sedate the patient with fentanyl and midazolam. They'll become more comfortable, and it has to be done as a sterile technique. The equipments needed for PNS guidance are, we need a 10 centimeters Stimiplex needle, a nerve stimulator, a cup for loading the local anesthetic. Normally we use 20 ml of 0.5% bupivacaine, and we add 10 ml of lignocaine of adrenaline and 10 ml of saline. So we make it as 40 ml in the sterile cup, and we need a 2 ml syringe for 2% lignocaine for local infiltration. We need a sterile marker pen and a scale. So these are all the equipments needed. The position of the patient will be a lateral position with a slight forward tilt, and the thigh is flexed. So this is the position of the patient. So coming to the lumbar plexus block PNS guidance, so you can see the patient lies lateral and is connected to the monitors. The back is painted with chlorhexidine solution, and the Stimiplex needle is flushed with a drug, and all the equipments are ready. The PNS is connected to the anterior aspect of the thigh, and the landmarks are, first you have to mark the PSIS. That is, you can see as a small dimple in the back of, that is the PSIS. And then we have to mark the iliac crest. So once you mark the iliac crest and corresponding to the higher point of the iliac crest, it meets the PSIS. So the next thing is, from the iliac highest point of iliac crest, you draw a line down, whereas this line meets with the opposite side iliac crest. So this is called as a Taffier's line or intercrustal line. The third one will be the spinal line, mid-spinal line, which is marked at the spinous process. The next is the most important one. You just connect the PSIS to the intercrustal line. So this is the most important landmark. So this is the point of insertion. Whenever you see this, if you measure from the midline to the point of insertion, it will be about 4 centimeters. And this 4 centimeters is fixed for even a thin patient and even for an obese patient, both are same. This 4 centimeters is same. And this is the point of insertion for lumbar plexus. So immediately after marking, just give a good local infiltration into the skin and subcutaneous tissue because it's a painful block. And after local infiltration, introduce the 10 centimeter Stimiplex needle. This technique is called as Vinnie's technique. What I'm following is the Vinnie's technique. When you introduce, it goes to the skin, subcutaneous tissue, erector spinae muscle, and then later you can meet some bony resistance. That is nothing but the transverse process. So once the needle hits the transverse process, we just stop there. You won't be able to go further deeper because of the transverse process. You can see the needle has hit the transverse process. So from that, we have to walk cephaloid to the slightly cephaloid to the transverse process. We can walk either cephaloid or caudal, whichever it is we can do, but cephaloid we usually prefer. So once you go cephaloid, and the most important thing is you should not go beyond 1.5 to 2 centimeters cephaloid in the transverse process. If you start with 1.5 milliamps, you'll be able to get a quadriceps switch. You can see the quadriceps switch will be there, and you start reducing the current from 1.5 So we can reduce it. Still the quadriceps twitch is there. You reduce it and you come up to 0.3 to 0.5 milliamps where the quadriceps stitch is there. So this, for this patient, the quadriceps stitch was there till at about 0.5 milliamps. You can see the twitch. And once it is present, that is the end point of lumbar plexus block. You start aspirating the drug and give every, you do aspiration for every 3 to 5 ml and inject it slowly. And the injection should be slow and should not increase, it should not go beyond 15 psi. So this is how a lumbar plexus block by PNS guidance can be done. And this is what I did is by Vinny's approach. There is one more approach, is called Capdevilla's approach, where we divide this arc into lateral 1/3 and medial 2/3. So this is the point of Capdevilla's approach. The only problem with this Capdevilla's approach is it's slight medial and it is very close to the dural sleeve. So the chances of epidural transmission is quite common. So we just follow the Vinny's technique. The goal for a lumbar plexus block is the distance from the transverse process to the lumbar plexus should always be 1.5 to 2 centimeters. So for even a thin individual and even an obese individual of any type of body mass index, the distance is 1.5 to 2 centimeters once you go towards the transverse process. Don't go beyond 2 centimeters. You may injure some of the abdominal viscera. So whenever you start with 1.5 milliamps current and slowly reduce until you get a visible palpable twitch of quadriceps between 0.3 to 0.5 milliamps. The possible depth for an lumbar plexus is 6 to 8 centimeters depth. The volume what we give is 20 to 25 ml. No need to go beyond 25 ml. In pediatrics, it is 0.7 ml per kg is the dose for lumbar plexus. Assessment of the block after lumbar plexus. So the onset time, it usually takes 15 to 20 minutes to complete the block. It takes 15 to 20 minutes for the onset of time. The first sign of onset of block is loss of sensation over the saphenous area. That is just above the medial malleolus of the leg. Just pinch, if there is no pain, that's the first sign of lumbar plexus block success. And if there is no pain on rotational movement and the patient is unable to extend the blocked leg, that's because of quadriceps weakness, then the block has taken. What are the pitfalls and corrections with the lumbar plexus? Suppose after walking over the transverse process, if there is no quadriceps contraction, that means what you have to do is you have to slightly deviate the needle 5 to 10 degrees, medial, lateral, cephaloid or caudal, you will be able to get a quadriceps contraction. Suppose instead of quadriceps contraction, there is only hamstring stimulation. There is only hamstring contraction. That means your needle has gone towards the sacral plexus. And that means the needle has gone more medially and there is high chance of epidural spread. So always withdraw and redirect it laterally. Suppose if you have both quadriceps and hamstring twitch, if both are present, that means your needle is close towards the lumbosacral trunk. So don't give the drug, always redirect the needle laterally. Instead of all these things, suppose if you get flexion of the thigh, it's because of psoas muscle, major muscle itself gets stimulated with the needle. So always withdraw and redirect the needle. So these are all the pitfalls on how to correct for getting a good lumbar plexus block by PNS guidance. Now we'll come to the sacral plexus block. So for doing a sacral plexus block by PNS guidance, we have to mark the ischial tuberosity. So this is the ischial tuberosity, and this is marked, and then you'll have already marked for the posterior superior iliac spine. So from posterior superior iliac spine to ischial tuberosity, from posterior superior iliac spine to ischial tuberosity, you just draw a line with a sterile scale, as you can see. And once it is marked from PSIS to the ischial tuberosity, you just divide this line into upper 1/3 and lower 2/3. So this is the point of insertion for sacral plexus into upper 1/3 and lower 2/3. So this is nothing but the Manzoor's point. And once it is marked, give good adequate local, then introduce the 10 centimeters uniplex needle perpendicularly. Once you insert the needle, you will be able to get a gluteal contraction. This is the gluteal muscle contraction. This is because of the inferior gluteal nerve getting stimulated. And once it is there, within a few millimeters, you will be reaching the sacral plexus. So there you will be getting a hamstring twitch, a gastrocsoleus twitch, and you will be able to get a plantar flexion of the foot. So this we will be getting at 1.5 milliamps. Slowly reduce from 1.5. You can, if you persistently get between 0.3 to 0.5 milliamps, this plantar flexion, that is the endpoint for giving a sacral plexus block. So for this patient, we got at 0.4 also. So after that, we have to aspirate and inject the drug. So since it is very highly vascular, we have to aspirate every 3 to 4 ml of drug whenever you give. And the resistance should also be low. Don't give it very high resistance. And this is how a sacral plexus block is given by PNS guidance. And you can see this is the depth of the needle. It's almost about 5 centimeters in this individual. After osseous contact, then the goal, after osseous contact, once you contact the sacral wing, it's always important you redirect the needle caudally and laterally. And you should not go beyond 2 centimeters from following osseous contact with the sacral ring for sacral plexus block. Problem is, if you go beyond 2 centimeters, you might injure the pelvic viscera. And the endpoint for the sacral plexus block is either a dorsiflexion or a plantar flexion. That should be present between 0.3 to 0.5 milliamps. Whereas another type of blocks, sciatic nerve, it's always plantar flexion plays an important role. The success rate is good whenever there's a plantar flexion. But for a sacral plexus block, we can give equal weightage for dorsiflexion and plantar flexion because at the sacral plexus, both the common peroneal nerve and tibial nerve are tightly packed. The depth, as I said, is 6 to 8 centimeters. The volume of drug what we give is about 20 ml. And how will you assess the block of sacral plexus block? There's no pain on pinching over the posterior aspect of the thigh. That means the posterior cutaneous nerve thigh has been blocked. Then you keep the hand just at the plantar aspect of the foot and ask him to push your hand. If you're not able to do that, means tibial nerve has been blocked. You keep the hand over the dorsal aspect of the foot and ask him to push up. If he doesn't do, then the common peroneal nerve is blocked. So you can see immediately after the block, we can ask him to lift the opposite limb. If he lifts nicely, that means there is no epidural spread. Whereas the blocked limb, you won't be able to lift. Then you can look for the lateral femoral cutaneous nerve and femoral nerve, and also the posterior cutaneous nerve of thigh can also be felt. We can also feel for any pain. So if it is not there, then it means it's a good lumbosacral plexus block. This is how we do a nerve stimulator guided lumbosacral plexus block. In certain situations, like, so this is a case scenario where we had a below knee amputation and a lumbosacral plexus block, and the patient came once again for above knee amputation after 2 days because the infection was spreading up in certain cases. So in such cases where there is no foot, we can't see for plantar flexion and all. So in such case, what is an endpoint for a lumbosacral plexus block for doing a redo, that is a revision amputation for an above knee amputation? The best thing is you can go to look for the gastrocsoleus twitch and also the hamstring twitch. So if you're able to get a hamstring and a gastrocsoleus twitch by 0.3 to 0.5 milliamps, that's an endpoint where we can give a block for redo amputations. Lumbar plexus block by dual mode. The next method is by dual mode, where we use both ultrasound as well as PNS guidance. So there are three types of scanning can be done. One is paramedial sagittal scan, paramedian transverse oblique scan at transverse process level, and Shamrock method. I'm going to go in detail about the Shamrock method for the dual mode. So in this, this is the video of the Shamrock method, where the points are marked as per the PNS guidance, and the lumbar plexus, that is the point of intersection, we give adequate local anesthetic infiltrating the skin and subcutaneous tissues. And after good infiltration, we keep the curvilinear low frequency probe just above the iliac crest. Once you keep it, then you will be able to see the structures there. Sorry. So after local infiltration, we just keep the probe and you'll be able to see the structures here. So we can see the bunny appearance where this is the psoas major muscle, and this is the erector spinae muscle, and this is quadratus lumborum, and this is the transverse process, and this is the dural or intrathecal sac, and this looks like a bunny's face, and this is the IVC. So the needle is inserted at the lumbar plexus point where you can see 10 centimeter stimuliplex needle is inserted here, where it goes in plane. And once it goes in plane, we can see the needle coming out at this point. You can see the needle coming into the psoas major muscle, and this is the psoas major muscle. Once the needle reaches the point where the lumbar plexus is present, so the lumbar plexus is here, then you can start stimulating the nerve stimulator. Start with 1.5 milliamps. Then once you start stimulating, when the needle comes close to the lumbar plexus, you'll be able to get a quadriceps twitch. So once you get between 0.3 to 0.5, you can start injecting the drug. So I can see the drug enters into the psoas major and blocks the lumbar plexus. So this is how a dual mode by a Samarov method for lumbar plexus is given. And coming to the sacral plexus block dual mode, we just mark the PSIS and the greater trochanter, and we keep the probe over the medial aspect of this line, and we will be able to see the iliac bone as a straight line. And once you scan it, you can see there will be a break in the iliac bone. So this is where the sacral plexus is present. And if you go nicely scan into that area, you'll be able to see the pulsating inferior gluteal artery, which you can see by the Doppler, and that the lateral to that is the sacral plexus. And then you start introducing the needle in an incline to the probe. So we just introduce this 10 centimeter stimuliplex needle into the probe. So you can see this after good local infiltration, we just insert the needle, and as it goes, we can see the needle in the ultrasound because it is an incline technique. We can see the needle tip also. So the needle is coming inside, and we bring this close to the sacral plexus, and the stimulation has already started. And from 1.5 milliamps, then if you get a good twitch between 0.3 to 0.5, that is plantar flexion of the foot at 0.3 to 0.5. So you can see the needle close to the sacral plexus. And once you start stimulating there, you can see a plantar flexion, so which is present at 0.3 to 0.5 milliamps. So then we can start injecting the drug. So this is how a sacral plexus block by dual mode can be done. And this is the paramedial transverse transverse oblique scan, where we keep the probe just above the paramedian line over the intercostal line, and we'll be able to see the same transverse process and body of the vertebra. And this is the psoas major. So this is another type of paramedian oblique scan can also be done for giving a lumbar plexus block. We can also use perineural catheters in continuous lumbar plexus block by Vinny's technique, because it minimizes the need of opioids for hip, femur, and knee surgeries. And more important here is the needle opening should always be facing cephaloid to facilitate catheter placement. And catheter is not inserted more than 5 centimeters beyond the tip, and the catheter has to be fixed nicely. And we can also use stimulating catheters for for a lumbar plexus block. And whenever you just stimulate the catheter, look for a quadriceps twitch and then inject the drug. You should always give as a continuous infusion. Whenever there is breakthrough pain, we can give intermittent boluses. So this continuous lumbar plexus block by perineural catheters can be used for limb-specific anesthesia which allows for early ambulation and effective physiotherapy. Coming to the complications of lumbar plexus block are from the needle puncture. So due to the needle puncture, direct trauma to the needle can be avoided. So always can be caused by short bevel needles. So always use Timiplex needles. There is a chance of intraneural injection if the PNS current goes below less 0.2 milliamps. There is a chance of damage to the abdominal viscera, like a kidney. It can cause a renal capsular hematoma if you go at the level of L3. Retroperitoneal hematoma can also happen if one of the lumbar veins get punctured. It can cause a big concealed hemorrhage, and hypotension can also happen. If you use catheters improperly, it can cause psoas abscess. And psoas major hematoma can also happen because of a needle and a vascular injury, which can later end in lumbar plexopathy. Then complications due to incorrect local anesthetic placement. Suppose if you go more medially, you have got more chance of entering into the epidural spread. The incidence is about 3 to 27%. So here these patients will have a lot of hemodynamic instability, which can cause hypotension, which will be disaster for the patient. And if you give with high pressure, injections are given with high pressure, can cause a spinal spread and causing total spinal anesthesia. Then comes the complications of local anesthetic. Intravascular injection can cause local anesthetic systemic toxicity. For a sacral plexus, if you go beyond 2 centimeters beyond the sacral wing, there is high chance of entering into the small bowel. It can puncture the small bowel, rectum, vaginal wall, or sometimes iliac vessel injury can also happen. So how to avoid complications with lumbosacral plexus block? The osseous contact is very important for a transverse process. Osseous contact of the transverse process is very important. And once you have an osseous contact with transverse process, don't insert the needle 1.5 to 2 centimeters beyond the transverse process. Always avoid medial angulation of the needle. Avoid high pressure injections. Use ultrasound to detect the needle tip and spreading of the drug. And avoid inserting, in case of sacral plexus, avoid inserting the needle 2 centimeters beyond the sacral wing of osseous contact. So to conclude, lumbar and sacral plexus block forms the sole anesthetic for the lower limb surgeries. It's safely used in patients with multiple comorbid illness and severe autonomic neuropathy. In PNS guided lumbar plexus block, don't go beyond 1.5 to 2 centimeters beyond the transverse process. In PNS guided sacral plexus block, do not go 2 centimeters beyond the sacral wing osseous contact. And perineural catheters are used for limb specific procedures, which allows early ambulation and effective physiotherapy. Thank you for your patient listening.
Hearty congratulations, sir. As the professor in charge of the splash surgery wing, you have done a commendable job. There are some questions for you, sir.
Yes,
Can we combine both sacral plexus block and lumbar plexus block together at the same time?
yes, sir. First, you have to give a lumbar plexus block, followed by that, we have to give a sacral plexus block.
And we reduce the volume.
Sir?
We reduce the volume. Total volume will be reduced to prevent loss and total toxicity.
Yeah, that's what we take is about, according to the weight, we take about 20 ml of 0.5% bupivacaine and 10 ml of lignocaine and 10 ml saline. So take 40 ml. So we can give 20 ml for lumbar plexus and 20 ml for sacral. So the minimum volume we can go for sacral plexus is about 15 ml. So we can go up to nothing happens. We can combine both of them. Give a lower limb, complete or lower limb anesthesia will be able to achieve.
The second question is, sir, can you add dexmedetomidine and clonidine to them, to the block?
Yeah,
Dexmedetomidine and clonidine for providing post-op analgesia also.
Yeah, we can also add dexmedetomidine and clonidine, sir. So usually this lumbar plexus block is for about 10 to 12 hours. If you add that, it will go beyond 18 to 24 hours. It's very effective also. For a good pain.
The third and final question is regarding sciatic block. Which is the most preferred approach? Somebody asked in the beginning of the lecture, sciatic block, which is the most preferred approach?
For a sciatic block, it depends on the trauma what you have. Suppose the patient has got like an open tibia, leg injury, it's very difficult to position him laterally. So in that case, we can go for an anterior sciatic block. If you are able to position him laterally, then the best thing is by the posterior.
Thank you very much. You've done well.
Mahesh garu.
Okay, Chapan sir.
Dr. Venkateswaran, I had noticed two important things. You have shared very good information. One is how to notice the epidural spread of the drug.
Yes, sir.
The second thing is how to proceed for an already amputated leg. That is very difficult to assess.
Yes.
That are two things I have learned today. Thank you very
Yes.
much, Venkateswaran.
Thank you, sir.
With the permission of the moderators, Dr. Kameshwara Garu, Dr. Mahesh Babu Garu, and my ISC leaders, Dr. Balu Venkat sir, and dear members, with your permission, I will take, let us take 10 minutes break to release the prestigious ISC AP newsletter. Over to our President, Dr. Muralidhar Joshi, and Secretary, Dr. Naveen Malhotra. I humbly request you to please release the ISC AP newsletter. Murali Joshi, sir.
Yeah,
Sir, sir, good evening, sir. This is for
oh,
you.
thank you, thank you so much for the flowers and all. I hope I would let receive that one in person, but never mind, but thank you so much, and respected dignitaries, the Commissioner, past President of Commissioner sir, Dr. Chakra sir, Kuchel Babu, past Secretary Dr. Bhimeshwar Garu, and past DC member Kiran, and of course President-elect Dr. Venkat Giri, and current Secretary Dr. Naveen Malhotra, ISAP President Dr. Venugopal Nori, and Secretary Dr. Srinivas, and so many stalwarts. If I keep on reading that will take almost 10 minutes. So I apologize if I missed somebody here and there, but never mind. But I'm happy about the way the ISA AP chapter has been doing the work during this pandemic spread. The ISA National itself is logging with doing the good job as Dynamic Secretary along with Dr. Vendra Sharma as treasurer. We are doing our innovative things, but I'm glad even the state banks are doing a great thing, and it's not an easy thing at this testing time to still get motivated to sit through a session or maybe to conduct a webinar like this with the family pressures, hospital pressures. Still, I think all the COVID warriors are putting a brave face. It's excellent, but it's a lot of good things to share also. I think India so far has registered with the lowest mortality in the world. I think most of the countries, they almost about 600 700 deaths per 10 lakh people, and India record about 25 deaths only per 10 lakh people. That's a big number. We don't know the reason that we're assessing. Is it because of the immunity, innate immunity, or the virus is weak, or vaccination? Nobody knows about it. But good news is good news. I think let's celebrate that. Nothing wrong about that one. To mark this lowest mortality with respect to the COVID-19 pandemic across India compared to the rest of the world, and I congratulate ISA AP chapter in this regard. Without wasting much time, I declare the AP e-newsletter is being released, and congratulations to all the members who have made it possible. And it's a fantastic one. I would like to say, after 15 webinars, AP e-newsletter, it's not a small thing. Congrats Venu, congrats Srinu, congrats Mahesh, and then Commissioner sir, Chakra sir, and it is fantastic phenomenon. Oh, that's great. That's great. That's great. That's great. That's great. That's nice. That shows the amount of dynamism has not been lost. That's what I'm trying to say. The dynamism in API has not lost, and that's the best part of Andhra Pradesh chapter has been. Each time you reinvent yourself with a newer thing, newer leaders, and newer thought, and newer generation. Like you don't get married to same people again and again. It's not a consanguineous marriage, but I am glad Venu. I'm glad Venu, Srinivas, and Dr. Mahesh, Commissioner sir, Chakra sir. It's not possible that TJ and Dr. Bhimesh and all of them seniors are there. And once again, I would like to congratulate Dr. Bhimesh for finishing the successfully completing the Chief of Examinership at NTR Health Institute. Dr. Bhimesh, congratulations for doing a phenomenal job. It's a credit to ISA. I would like to take it like my own strength. You are my secretary, so I still take it like pride, like you did that one. That's commendable job, administrative. And once again, I wish the team from Ganga Hospital fantastic job, and I think the great lectures and all. Would not like to interfere too much in the scientific program. All the best, everyone. Fantastic faculty.
Thank you, sir.
All the best.
Thank you,
Have
sir.
a great discussion. Thank you.
Thank you,
Take
sir.
care. Take care.
Thank you, sir. Dr. Naveen Malhotra, sir. Dr. Naveen.
Good evening. Am I audible?
Yes, sir. Yes, sir.
Yeah. Good evening, everyone. Dr. Muralidhar Joshi, President ISA National. Dr. Past Presidents, Dr. Chakra Rao sir, Dr. Kameshwar Rao sir, Dr. Kuchela Babu. My past Secretary ISA National, Dr. Bhimeshwar, and GC member Dr. Kiran Gera. Dr. Tagore and other office bearers of AP State Branch. I'm really happy when Dr. Venu told me a few days ago that they're going to launch ISAP newsletter on 1st of August. And really heartiest congratulations to whole of the team of Andhra Pradesh, led by Dr. Venugopal and Dr. Srinivas Rao Surisetti. Webinars have been going on very regularly in AP and almost twice a month or maybe more. And this is another feather in the cap, as well as recently AP won the prize in the ISA social outreach program held on the World Environment Day. And I can just say that Indian Society of Anesthesiologists is committed to the safety and welfare of all its members in this COVID pandemic. And whether it is guidelines, procurement of PPE kits, licensing with the government, online academic programs, which AP is doing an excellent job, health insurance scheme, mechanical ventilation training, and so on and so forth. Anesthesiologists are doing an excellent work to the humanity and mankind in this COVID pandemic. As per the reports available with ISA National Headquarters, 60 to 70% of the anesthesiologists who are donning PPE and working in COVID areas are anesthesiologists. And ISA National salutes this team of UISA, which is being guided by senior anesthesiologists very, very exceptionally, very, very nicely. And both seniors and juniors are together doing, both are doing exemplary service in this COVID pandemic. I once again congratulate the whole team of Andhra Pradesh for bringing out this ISA PPE newsletter. Best wishes. Long live ISA. Jai ISCM. Jai Hind. Thank you very much.
Thank you, sir. Thank you very much. Over to the moderators, Dr. Kameshwara Garu and Dr. Mahesh Babu.
Dr. Mahesh Babu, proceed with the second speaker. Dr. Mahesh Babu, please introduce the second speaker.
So I didn't have the biodata of him, sir.
You didn't have
Yeah,
the
Dr. C. Madan Mohan. He's done his MD and DNB and PDF NB, and he's the junior consultant anesthesiologist from the Ganga Medical Center and Hospital, so Coimbatore. Over to Dr. Speaker, sir.
Thank you very
Dr.
much.
Madan Mohan, please.
Thank you very much, sir.
Thank you.
Good evening to everyone. And first of all, I would like to thank ISA Andhra chapter for giving me this opportunity, and also Dr. Balangit sir for believing me to deliver this talk on sedation in regional anesthesia. So why we are bothered about sedation in regional anesthesia? Sedation in regional anesthesia is an important integral part which can make regional anesthesia comfortable, as well as some of the deep sedation will make the regional anesthesia very much comfortable while administrating, say for a lumbosacral plexus block or in patient whom the central neuraxial blockade can be given, like in pediatric patients and all. So before going to the topic, we'll have some case scenario. So this is a child 6 years old who has fallen and developed a supracondylar humerus fracture and having a distal pulse deficit, came with a full stomach and having an active UR rate, and surgeons wants to fix the bone as early as possible. And patient, as obviously child is not highly uncooperative and not allowing to touch us. So how we are going to proceed this case? Second case, these two are the cases of open reduction and internal fixation of elbow joint, and second one is a clavicle surgery where regional anesthesia has been instituted and patient is comfortable and not having any pain at the surgical site. But because the position for the first thing, the patient is in a lateral position, and the second thing is a beach sitting position. They may be comfortable at the start of surgery. As the time passes, say after an hour, patient will slowly having discomfort in the position. They will have pain in the pressure points. So we need to make third scenario what we have is pelvic fractures. The pelvic fractures, mainly acetabular fracture or pelvic fracture coming for open reduction and fixation. Neuraxial anesthesia is the plan of anesthesia for these cases. But because of the surgery injury, they are not able to give appropriate position for
central neuraxial blockade. Either it may be a sitting or a lateral position. So in these cases, we need to give a deep analogous sedation so that the patient can give adequate positioning for the central neuraxial blockade. So with these case scenarios, we'll go to the proper topic. So for a definition, sedation is a drug-induced depression causing consciousness, during which the patient will be arousable. They will respond to verbal commands and even to the right tactile stimuli. This is a procedural sedation. And the airway will remain patent, and there will not be any need for intervention to keep the airway patent. And the ventilation will be spontaneous and adequate. And whenever the sedation is constituted, we need to monitor the cardiovascular and respiratory system by the necessary monitorings which we have. So to start with continuum of depth of sedation, sedation ranges from mild sedation to a general anesthesia. So 4 things we need to consider. First is responsiveness of the patient. Second thing is airway. Third is cardiovascular system. And fourth is respiratory system. So with minimal sedation or anxiolysis, where a mild sedation alone is given, patient will remain quiet and they will respond normally. They will speak normally. All the other parameters will remain unaffected. The moderate sedation or procedural sedation, which was previously called as conscious sedation, is the one which is widely established during the regional anesthesia procedure, where the patient will give a purposeful response whenever we ask their name or anything else, and they will be giving a good response to a tactile stimulation also. The airway will remain protected, and there will not be any need for maintaining the patency of the airway. And obviously, ventilation as well as cardiovascular functions will remain normal. But for deep sedation, if we take, the patient will respond only to a painful stimuli or repeated verbal stimuli, and patient may lose the airway. We may need to do some interventions to keep the airway pattern. And most of the time, the ventilation will be adequate, or sometimes it may be hypoventilation, which we may need to supplement with oxygen to maintain the saturation. And other extreme is the general anesthesia. So why we need a sedation in regional anesthesia? So before going with any regional procedure for mainly anxiolysis, whether it may be a pediatric or a elderly patient, or even in some of the adult patients, mainly the female patients, they will have extreme anxiety over the surgery and into the hospital environment. So we need to give adequate anxiolysis. And during the time of regional anesthesia procedure, to make the patient comfortable for positioning, whether it may be a central neuraxial blockade or a peripheral blockade, and during the time of needling, if the patient is very much anxious, they keep on moving, and we may lead to injure some of the vital structures during the needling. So we need to make the patient comfortable while doing regional anesthetic procedures. Then during the surgical procedure, mainly to supplement the inadequate or incomplete anesthesia, regional anesthesia. Some of the, say if you take a myofascial plane block, like a serratus anterior plane block with a thoracic paravertebral block, which is the sole anesthetic for a breast surgery, it may not be 100% like 100% for the surgery. Patient may have some discomfort or even pain. So we need to give some adequate analogous sedation like dexmedetomidine or opioid infusion like that. And also for certain uncomfortable positions like lateral position, semi-prone position, sitting position, we need to make the patient comfortable for long surgeries. So we need to give some adequate sedation. So what are the cautions and contraindications? So whenever the patient is having inadequate NPO or full stomach, we need to consider twice before giving any form of sedation. Of course, mild sedation where the patient remains calm, it's acceptable. But for going to the deep sedation, we need to be cautious. And for patients who are having head injury with raised ICT or altered sensorium due to some electrolyte abnormality or acid-base imbalance, we need to preferably avoid sedation in those kind of patients. And for obvious reasons, OSA is highly contraindicated unless we are ready with tackling the airway. And for morbid obesity, though patient may not give history of snoring, and we need to be more vigilant whenever we are instituting sedation in these kind of patients. And for patients who are on substance abuse, so for chronic abuse, we may need to give more dose compared to a normal person, which may give its own adverse effects. And for patients who are on acute substance abuse, say for who are patient coming with alcohol intoxication, whenever we institute sedation in these patients, they may land up with developing delirium in the postoperative period, again, which will lead to morbidity. So whenever we are instituting any sedation, we need to keep our equipment ready. So out of all this equipment, two things I need to insist. One is airway. Nasal as well as oral airway should be available and it should be appropriate for the patient. Second thing is self-inflating bag, that is our ambu bag with an appropriate size face mask, because whenever the patient loses airway and started desaturating, we may find it difficult to get the oxygen source, because some of the blocks will be instituted in the pre-op holding area where the oxygen supply will not be checked before doing. And again, we may need to get an ambu bag and all. So whenever we are doing, just make sure two things: the airway and the self-inflating ambu bag with the appropriate size face mask is available. So some of the guidelines given by the leading societies for what are the monitors required whenever sedation is instituted. So assessment of depth of sedation, again, it can be done using some of the sedation scales or using some of the monitors like BIS monitors and entropy. Again, availability of the monitor and cost are one of the factors impending. And coming to blood pressure measurement and pulse oximetry, all the leading associations are recommending to measure the blood pressure as well as continuously monitor the SpO2. And ECG, whenever deep sedation is required and patient is having some ECG changes in the prior to the procedure, it's better to incorporate ECG in the monitoring. And capnometry, again, if it is available, it's better to use so that we can pick up hypopnea and keep the airway pattern and prevent further desaturation. And because of inavailability, sometimes we may not be able to use capnometry, but if it is there, it's better to use. So coming to ideal sedative agent. So any ideal sedative agent should have a rapid onset of action. You should act within minutes so that we cannot wait for the action to come and we can save time. And again, it should be easily titratable and it should have a short context sensitive time. If the context sensitive time is very much less, say for a amifampridine it's 3.5 or propofol is around 8 minutes. So for whenever you are giving a continuous infusion, we can expect how long time will be taken for the drug to get eliminated and patient will come back to a normal state. And it should have a rapid elimination from the body. And most importantly, it should not have any cardio and respiratory depression and other side effects. And lack of tolerance and withdrawal symptoms should not be there. And of course, patient any drug which is used should be inexpensive without any drug interaction. So we'll quickly run through the sedation drugs and analogous sedation drugs which we are routinely using in our day-to-day practice. So starting with benzodiazepines. Benzodiazepines, they act in the GABA receptors and potentiate the inhibitory effects by blocking the chloride channels. So commonly used benzodiazepines are the midazolam, diazepam, lorazepam, alprazolam. Of this, most of them are given intravenously and intramuscularly, and drugs like lorazepam, alprazolam, and diazepam are given in the day prior to the surgery to make the patient comfortable and have a good sleep overnight. And other than the hypnosis, it also provides anti-growth amnesia. So patient awareness after the surgery will be lesser compared to others. And flubacenil is an antidote which recovers the action of the benzodiazepine, though it is not commonly used. Of course, we have one drug. So if in case more drug is being used and we need to reverse the effect, we can make use of it. So midazolam. Midazolam is the most commonly used sedation in regional anesthesia, because it's short acting and it's immediately acting, and we can have a predictable recovery. Compared to the others, the T-off is very much less, 2 to 4 hours, compared to diazepam, which is lorazepam, alprazolam, they are around more than 10 hours. And of course, midazolam at higher doses can cause respiratory depression. So patient may land up with hypopnea or apnea. So whenever we are giving higher doses of midazolam, we need to be very much vigilant. So these are the various routes available and the dosage. So most of the time we prefer intravenous, and for pediatric patient, we prefer oral or nasal. Rectal dose, we are not using much. Coming to propofol. Propofol again is a very good drug for a sedation, especially for a continuous infusion in the perioperative period, because its onset is very fast and even the offset, and the contact sensitive time is about 8 to 10 minutes only. And again, it has an antiemetic effect. And whenever propofol is instituted, all standard monitoring is recommended, and saturation has to be monitored, and we may need to supplement oxygen to prevent hypopnea and desaturation. The loading dose is usually 0.2 to 0.5 mg followed by the maintenance dose. If we have TCA pump, we can make use of the preformed models like Kataria model for pediatrics and Marsh model for adults, where the effector site concentration will be set up, and we can make use of the TCA for the entire perioperative period. Coming to ketamine. Ketamine is a very good drug, especially for regional anesthesia in a highly uncooperative patient and in a patient who have very difficulty in giving the position for the pertaining block. It gives a dissociative anesthetic and it's a very good analgesic. Even for a incomplete or inadequate block, we can make use of ketamine in the perioperative period and tide over the pain or discomfort developed during the time of surgery. Again, it has a very rapid onset. Within a 90 seconds, around 1 minute, we'll have the onset, and the duration is usually around 15 to 30 minutes. And those what we used to give here is around 0.2 to 0.75 mg per kg IV. Or for a pediatric patient in whom the IV line is not available, we used to give around 2 to 4 mg IM. And once the child is sedated, we will go for IV line. And infusion, the dose is 5 to 20 microgram. We are not much using infusion. And one thing is, in adult patient, whenever we use ketamine, there may be chances of emergence delirium. So whenever ketamine is used, better to give any benzodiazepine or at least propofol to prevent the emergence delirium. And coming to dexmedetomidine, it's a wonder drug which has been introduced into the regional anesthesia, and it has very good anxiolytic property, analgesic as well as amnestic. Other than that, it causes, it can even prevent shivering also. And the onset is slightly slower compared to the drugs which we saw previously. And it usually takes 5 to 10 minutes for the onset, and the peak effect is usually achieved around 20 to 30 minutes. So whenever we are planning to start dexmedetomidine for a surgery, especially for a lateral position or even a sitting position, it's better to start 20 to 30 minutes prior to the skin incision. So the patient will be very much comfortable during the start of surgery. And we start with the loading dose of 1 microgram per kg, and the maintenance is around 0.2 to 0.5 microgram per kg per minute. Main thing, whenever you use dexmed is, patient may have a brief episode of bradycardia and hypertension initially due to the alpha 2 B receptors, followed by the hypotension episode due to the A receptor stimulation. So we need to be continuously monitor the blood pressure and heart rate and treat accordingly. And we have antagonist atipamezole, which is an alpha 2 antagonist, which can reverse the dexmedetomidine effect. Again, these drugs are very rarely used in the day-to-day practice. Then opiates. Opiates, of course, we have variety of opiates for sedation as well as analgesia in the perioperative period. One of the most important is fentanyl. Since fentanyl has an immediate onset and short duration of action, it's being used for sedation as well as analgesic sedation in the perioperative period. So it has a rapid onset, and it acts quickly, around 2 to 3 minutes from the administration of IV, and duration of action is usually around 40 to 45 minutes. And those usually for sedation is around 1 mg. Sometimes for pediatric patient, we can step up to 2 mg per kg. And for continuous infusion, though very rarely used in the perioperative period, we can make use of 1 to 3 mg per kg per hour. And of course, like any other opiate, it has some cardiorespiratory depression effects. But compared to other drugs like morphine, other morphine counterparts, the depression will be slightly lower, reduced, and short acting also. So preferably, this is a good drug compared to others. And remifentanil availability is the only issue, but it again has a very good pharmacokinetic profile, and it is again a mu receptor agonist. It's act very rapidly within a minute, and it has the shortest context sensitivity time at around 3 to 3.5 minutes. And we can expect very minimal respiratory depression whenever we use the remifentanil. And the infusion rate is usually 0.1 microgram per kg per minute. And only problem is the availability of the drug. It's not available everywhere. Coming to the target controlled infusion. Target controlled infusion has its own advantage compared to a manually induced infusion. What TCA does is it uses microprocessor to control algorithms based on pharmacokinetic model. Everything will be preset and various models will be available. We just select the drug which we are going to use and the model we are going to use, and we need to set the effector site concentration. So for usually we use propofol for TCI here, and we set up at 0.4 to 0.8 microgram per ml, which will give an adequate sedation. And again, patient will be very much comfortable when the regional anesthesia is appropriate. Some of the advantages of TCA is, since the drug used compared to a manual sedation is less, the adverse effects of the drug used is reduced. So mainly nausea and vomiting will be less whenever opioid is being used using TCA, and the quality of recovery compared to a manually given sedation is better in case of a TCA, and level of sedation can be easily adjustable, which may not be possible in a manual, because once we give a bolus dose, we need to wait for some more time for the sedation level to come down. But here we can just alter the effector site concentration by just altering the dosage. Disadvantage is again availability and cost, and there is no ability to monitor the concentration changing at the real time. Again, patient control sedation is also available. If it is available, we can make use of it. Again, just like a patient control anesthesia, it will deliver the necessary anesthetic, and it has an awkward period can be kept depending upon the patient profile, and total consumption of any drug which we are using can also be reduced once the patient control sedation is being used. So coming to the assessment of level of sedation, we have various sedation scale or scores to assess the level in which the patient is. Some of them I'll just run through. One is Ramsay sedation scale. In this patient, in this scale of 2 or 3 will be sufficient for a patient who is undergoing surgery in regional anesthesia is preferable. And another one is Wilson's sedation score, and this is observer's assessment and of alertness and sedation scale. In this, we prefer 4 or 3 score to be present in the patient whenever they undergo any surgery in the regional anesthesia. So coming to sedation in geriatric patient, again geriatric population, most of them will have some of the age-related problems, and they are more sensitive to sedative drugs, and because of the slower metabolism, the drug elimination will also take more time. So whenever we are instituting sedation in these kind of patients, you should be double cautious, and they have a smaller volume of distribution and prolonged observation period after sedation is there. We generally don't prefer sedation in geriatric patients unless they are restless prior to the surgery or during the time of surgery. And some of the patients which we receive will be already delirious because of the trauma and the pain. So in those cases, we may need to give appropriate drug to make the patient calm during the surgery. And we prefer haloperidol and dexmedetomidine to make the patient calm. Again, whenever we are giving these drugs, patient will remain sedated for a longer time. They may not be able to take orals, and again, relatives will be more concerned whenever the patient is keep on sleeping. And in these cases, we prefer to not to use benzodiazepine, and because whenever these uses, the sedation becomes very much more, and patient may even become delirious more. So coming to pediatrics, and pediatrics is yet another population where sedation is almost must whenever the child is very much less of age, like say 10 years or less. They will be highly uncooperative. They won't let us to secure an IV line, and even parental separation is a great concern. So we need to make the child calm before taking into the operating room or pre-op holding area. So deep sedation again is mandatory for any regional procedure, because whether it is a neuroaxial procedure or a peripheral nerve block, without a deep sedation, it's not possible. Child will keep on moving and crying like anything. We will be more stressed compared to them, and ultimately the procedure may even land up with a failure. So we prefer oral sedation or nasal sedation depending upon the time, the surgery, availability of the time, as well as drugs. So if we have enough time for the surgery to conducted, we prefer to give a oral sedation. And nasal sedation, if again we tend to give dexmedetomidine as well as midazolam, and of course we need to give it using atomizer, then only nasal sedation will be a good one. Other than that, IM very rarely we give. Rectal routes we are not preferring, and orally previously we were giving chloral hydrate at 30 to 50 mg per kg. At present we are not preferring that. Sometimes we make use of promethazine syrup 0.5 mg per kg, And midazolam is the main drug which we prefer for a oral sedation. And midazolam syrup is not available here. So we make use of the IV sedation with some sweet 25% dextrose 2 to 3 ml and make use of it. And dosage is 0.75 to 1 mg per kg. And along either midazolam or along with that ketamine also will be given in the same dose. And this will act within 10 to 15 minutes and make the child calm who can cooperate for an IV line. And but for a painful procedure like a peripheral nerve blockade or a neuraxial blockade, you may need to give some IV anesthetic once the IV line is secured. And nasal, again, Dexmed, we are giving around 3 to 4 mg per kg, and midazolam 0.2 to 0.4, and ketamine 0.5 to 8 mg. And whenever the nasal drugs are given, it takes roughly around 20 to 30 minutes to act, and we may need to little patient to get the necessary sedative effect. And this guidelines gives, which was came in RAPM 2015, the pediatric regional anesthesia, it's better to do under deep sedation or GA, because whenever this is patient's sedation is deep or under GA, we will get an acceptable safety, and the procedure can be done with utmost care because child is calm, not jumping around, and we may prevent the needle related injuries. So once the patient surgery is over, is it in the post-operative ward, we need some guidelines to discharge the patient from post-operative ward to the rest dependency unit or even to home in a daycare procedure. So for that, patient needs to be alert and oriented. For pediatric patient, child should be wide awake and able to recognize their parents. And there should not be any cardiovascular abnormality or any hypertension or tachycardia, bradycardia. Those should not be there. And airway should be patterned. All protective airway reflexes should be available, and no postoperative nausea, vomiting, and acceptable vital signs. And only patients, those who are discharged on daycare procedure, should be accompanied by a appropriate person, and necessary instructions should be given, say for a lower limb block or for upper limb block, how long the time will take to regression, and what are the things to be noticed, and when to come back or when to call if there is any abnormality. So those things should be given. And coming to sedation in regional anesthesia, especially in this COVID pandemic, we have made our own protocols for this pandemic. What we have instituted is, we prefer not to sedate the patient in this pandemic until it's 100% necessary. Okay. So we make the regional anesthesia 100% successful, so that we may not require a supplement interop. And again, we may need to, once the patient goes for apnea or hypopnea, we may need to keep the airway pattern and doing some airway procedures which may lead to aerosol generation and leading to infection of the healthcare workers. Again, whenever this is needed, we have to make use of a proper PPE before airway manipulation. So that is why we have, whenever possible, we are avoiding the sedation in the perioperative period. But of course, for some cases like highly uncooperative patient or a pediatric patient, we have to make use of sedation. So how we are doing? So for the first case, the pediatric case, once the child is receiving the period holding area, we give midazolam plus ketamine at these doses. And once the IV cannula is secured, we will be giving standing dose of ketamine. Just usually, if ketamine is given in the oral, the dose can be reduced to 0.5 to 0.5 mg per kg. If in case oral sedation is given only with the midazolam or dexmedetomidine nasal sedation, we will be giving 1 mg per kg of ketamine. Once the child is completely sedated and there is no response to any stimuli, we'll go with the ultrasound guided peripheral nerve block or neuraxial blockade. And intraoperatively, depending upon the duration of the surgery, we'll be giving intermittent boluses of propofol, and of course we will be adding some opiates, mainly fentanyl, 1 to 2 mg per kg. So for position, uncomfortable position cases, say for a lateral position or a sitting position, and prior to block, we are not giving any sedation, only if the block is a deeper block, say for a lumbar sacral plexus block. Other than that, we are not giving sedation for peripheral nerve blockers. And once the block is instituted, the moment the patient enters the OT, we'll be starting the dexmedetomidine injection. 1 mg per kg over the 10 minutes, and it will be followed by 0.2 to 0.5 depending upon the vitals of the patient. And patient will be very much comfortable. Even we have done 3 to 3.5 hours surgery in lateral position with the dexmedetomidine infusion alone with an adequate regional anesthesia. And for pelvic cases, whenever possible, say for a anterior acetabular fracture or even a pubic ramus fracture, we are giving pain block. Though it may not give a very good analgesia, it will cut off some component of the pain. And once the patient is wheeled inside the operating room, we'll be giving a ketamine as well as fentanyl and make the patient completely calm and deeply sedated, and make the position lateral or sitting. Whenever the positioning is done, it's mandatory to keep the patient in a appropriate position, and the neck should be supported, and oxygen supplementation should be attached, and necessary monitoring to be given. And of course, patient may, since deeply sedated, they may tend to fall. So at least 2-3 persons should be available to hold the patient in position. Following that, and depending upon the position, say some of posterior acetabular fracture will be done in the lateral position. For those cases, we will be giving dexmedetomidine infusion along with some opioids. But for a supine position, we'll just maintain with the midazolam or even opioids. So thank you. Any queries?
Mahesh garu.
Any questions?
Thank you very much.
Venkateswaran.
For all groups, pediatric, geriatric, and normal all groups, have done an excellent job. But the problem is remote currently not available, so majority of people switch out to only medetomidine currently. Of course, the ketamine is the easier choice for all type of blocks. There we can, if the block is not sufficient, we can control the pain with ketamine. Good job, congratulations. I'll hand over the proceedings to Commissioner, sir.
Dr. Mahesh Babu garu.
Very good.
Dr. Venkateswaran, very nice presentation. I have seen one thing, that is the nasal dexmedetomidine you have mentioned it. Dr. Mahesh Babu, did you share anything about the nasal dexmedetomidine? Because I didn't use here in any place.
Sir, we used it to prepare for only this thesis purpose only. We have done it, sir. Not routinely, we are not doing it. We use both the oral dexmedetomidine, nasal dexmedetomidine, oral midazolam, nasal midazolam. We tried everything, but it is unscientific because we have to prepare the same one. What they are using for IM and IV use, to prepare that with the honey or some sugar base and do it. In nasal one, you need to take normal saline and spray it. But the problem is here, the composition can't be maintained uniformly, and the effect may not be seen what we see with IV or IM injection. So all things are studies. Unless you get a perfect form for that, we can't use them. So always the preferred one is IM or IV is better always.
Here we have atomizer to injections. So
yeah, we can do that. We can do that.
With that, good effect.
Yeah, but oral midazolam, we used to have a spray of midazolam spray. One company used to market that midazolam spray. Even the pediatrician used it to use for even epilepsy and convulsions. But somehow they withdraw that from the market. So now that spray is not available now.
What about the predictability of the absorption?
Yeah, IM midazolam.
Beg your pardon, sir?
Predictability of absorption, it will be absorbed in the nasal. Of course, it will be faster in absorbing.
Yes, sir.
The amount of absorption and the local condition of the nose and all those things.
Yes, sir. Yes, sir.
How do you predict?
Again, patient is having some pediatric patient having some running noses and don't
Yes,
nasal sedation because for obvious reasons the secretion will prevent the absorption of the drug. For those cases, we'll go for either IM or oral sedation. But other cases, we generally see a very good effect, and it usually takes around 20 to 30 minutes for the child to get calm and cooperate for any invasive procedures.
Both the lectures are very good, really very interesting. Dr. Venkateswaran and Dr. Madan Mohan
Thank you, sir.
both highlighted very well about this block and also about the sedation aspect. Both are nicely highlighted, including the pediatric aspect of sedation also is covered. Very well. Dr. Balavenkat is there?
Sir just left. He had an urgent work, sir.
He has an urgent work. Thank you very much for the nice lectures you have given, both of you.
Thank you so much.
Thank you, sir. Dr. Kameshwara Garu. May I
Yeah.
request our secretary, Dr. Susati Srinivas, or Treasurer Achit Ramay, if there is any board, please conclude with a vote of thanks. Achit, Treasurer, or Srinivas,
Dr.
Treasurer.
Venu, when do you circulate this newsletter?
Just now, sir. Just now, I already circulated. You can check your WhatsApp.
Okay, you're sending by WhatsApp.
Yes, sir. Yes, sir. So, vote of thanks by Dr. Srinivas, Surseti Secretary. Srinivas, are you there on the board?
Yes, sir. I just unmuted him. Srinivas, sir.
First of all, thanks to our National President Dr. Muralidhar Joshi Garu and our Dynamic Secretary Malhotra Garu and all the stalwarts, Dr. Chakrao Garu, Dr. Kameshwara Garu, Dr. Ramesh sir and Dr. Geera Kiran. And today, heroes both, the speakers, Dr. Venkateswaran and Dr. Madan Mohan. Very beautiful lectures, sir. Very nice academic piece too, because these are all the, especially for sedation. The blocks we are seeing, but sedation is elaborated and covered all the from geriatrics and pediatrics, everything. And thank you very much, sir, for sparing your time to ISAAP. And thank you one and all for participated actively in the ISA webinar. Thank you all.